Good morning, sir.
Good morning. Today we will have a case discussion on carcinoma thyroid. The case will be presented by Dr. Uma Murmu, who is a second year junior resident at IPGM SKM Hospital, and Professor Saurabh Ghosh, who is Professor and Head of Surgical Oncology at Calcutta Medical College, who will moderate the session. So, Uma, you can share your screen, present up to history. Wait, we have some discussions on history, and then proceed to the examination, and then further discussion. Okay, Uma, please share your screen and start presenting. Uma, your audio off, and I was seeing your screen. Please share screen and start. Yes, Uma, you can start.
Okay. Good morning, all of you. I am presenting the carcinoma thyroid case. Starting with the patient's particular, she's Mrs. X, age 46 years.
Share your screen. We cannot see your screen.
We can see it now.
Slide. You can see it?
Yes.
Okay.
Oh, okay.
Okay.
Residing at Kolkata, homemaker by occupation. Her complaint was swelling in the front and left side of the neck for past 12 years. History of present illness. The patient was apparently asymptomatic 12 years back when she noticed a swelling in the front and left side of her neck. The swelling was insidious in onset and gradually progressing. Initially small in size and increased in size suddenly in last 6 months and involved almost whole of the left side of her neck. It is associated with mild respiratory distress while lying down at night for last 3 months. No difficulty in swallowing or breathing. It is not associated with any pain. No history suggestive of hypo or hyperthyroidism like insomnia, increased sweating, tremor, weakness, or increase in appetite or decreased appetite, diarrhea or constipation like this, or palpitation. So no history suggestive of hypo or hyperthyroidism, and no history suggestive of distant metastasis like bone pain or hemoptysis. In her past history, she is diabetic for last 3 years and she is hypertensive for last 3 years, and she is under medication. No history of any irradiation. No history of thyroid malignancy in the family or neighborhood. Her personal history. She's married. She is on a mixed Bengali diet. No history of any substance abuse. She is allergic to prawns, eggs, brinjal. Her bowel bladder habits are normal, sleep normal. Her menstrual history, her menarche started at 13 years of age and her cycle is regular. She is still menstruating. 2 living child. Sir, should I proceed, sir?
Yes, complete the history.
Okay. In the general clinical examination,
No, wait for the examination. Just wait at the history.
Well-lit room after taking her consent. Oh, okay, sir.
Okay. Dr. Ghosh.
Dr. Uma, so could you just go back to the past history, please? One slide before this. Okay. No history of any what irradiation do you mean here? What irradiation is important in the past history?
No, sir.
It is specifically irradiation to the neck region. I mean, if a patient has been treated for say sarcoma of the leg, for which he has received radiation to the leg, probably that is not going to increase the risk of developing a thyroid cancer. So history of repeated irradiation to the neck, even by say multiple chest x-rays during childhood, may increase the risk somewhat. Or if the patient has been exposed to some kind of radiation hazard, like in a nuclear accident or something else like that, that you have to specifically mention. So not any irradiation to the neck, at least add that.
Irradiation to the neck.
Going back to the present history, you said that she is having dyspnea on lying down, but in the next line you are saying no difficulty in breathing. So
no, in sitting posture or in during walking or anything.
So, but if there is distress, don't have to add that she is not having any difficulty in breathing.
Oh, okay.
At all. So maybe you can add that in that line when you're saying it, that the patient that does not have any dyspnea or difficulty in breathing when she is sitting or supine, but when she lies down, then she has a difficulty. What is
mild
that
respiratory distress.
What is that called? There's a term for that.
The postural dyspnea.
No. Dyspnea, I don't think it's right. Orthopnea.
Orthopnea.
When the patient is sitting up, she is fine, or he or she is fine, but when they're lying down, they're having difficulty. So that is not uncommon with thyroid swellings. And maybe just another thing you could have mentioned there was any change in voice. I don't think you have mentioned that.
No, sir, there is no change in voice. Sir.
So you have to mention that. That's an important negative point. So pressure on the trachea or larynx, lower end larynx and trachea causing difficulty in breathing. Pressure on the esophagus causing difficulty in swallowing, which you have mentioned, and pressure on the nerves causing a change in voice. These are the three local pressure symptoms that you have to mention. Other than that, you mentioned most of the things, I think. Maybe sir can add something.
In the family history, you mentioned about there is no thyroid malignancy in the family. At the same time, you say no malignancy in the neighborhood. How malignancy in the neighborhood can affect this patient?
Actually, the swellings in the neighborhood, basically like goiter region.
That is true of endemic goiter. That is true of endemic goiter. If your neighbor has some thyroid swelling, these are endemic goiter. Okay, so patient having a family history means something. Why is family history important in thyroid malignancy? What thyroid malignancy may run in families?
Sir, medullary carcinoma thyroid.
Medullary carcinoma. Apart from that, do you think some papillary carcinoma also has some genetic background? Now there are a lot of tests that come up. Any patient of papillary thyroid carcinoma may have some familial background.
Yes, it is an important for you. Familial papillary thyroid cancer is a well-dependent. Okay. You must know that.
Okay. And patient is said hypertensive. Do you need to specify something more from the hypertension? Because she is swelling for 12 years and then for last year she is hypertensive. Any other history in hypertension is important?
Sir, the pheochromocytoma.
And what history is important? You can suspect patient might have pheochromocytoma. What is the pigment of hypertension? What is the pigment of hypertension?
Episodic hypertension. Sometimes she will have history. Sometimes it will be normal. It may be.
Patient may have blackouts. Patient may have
headaches.
Yes, sir. Hypertension, headache in the pheochromocytoma.
But most are essential hypertension. But on the background of a thyroid swelling, if you have a recent onset hypertension, then one should consider these points to exclude a swelling pheochromocytoma. Okay, I think she can proceed for examination.
Yes, sir. Yes. Comprehensive history, good history.
In general clinical examination, I have examined her in a well-lit room after taking her consent. She was alert, conscious, cooperative, and well-oriented to time, place, and person. Well-built. Hydration status was adequate. She is well-nourished. Her face is normal. Temperature afebrile. Heart rate was 88 per minute. Blood pressure was 118/74 millimeter of mercury. The respiratory rate 16 per minute. No pallor or icterus, cyanosis, or clubbing or pedal edema. In the loco-regional examination, in inspection, I have done in sitting position with the neck slightly extended. The swelling is in front and the left side of the neck, situated in the anatomical location of thyroid region. Extending laterally up to sternocleidomastoid in the left side, superiorly up to angle of the mandible on the left side, and inferiorly above the suprasternal notch in the midline and up to medial 1/3 of the left clavicle on the left side. A nodular surface, ill-defined margin, and it's moving up and down with the deglutition. Lower border of the swelling is visible. No skin changes, scar, sinus, or fistula. No stridor. Pemberton test was negative. No engorged veins over the neck. No venous prominence over the chest wall. No visible pulsation. No inspectory findings suggestive of thyrotoxicosis. On palpation, done after taking proper consent of the patient with her neck slightly flexed, local temperature was not raised, non-tender. The swelling was non-tender. Surface is nodular. Margin is irregular, hard to firm in consistency. Isthmus was 3 into 3 centimeter, extending from 2 centimeter below the thyroid cartilage to 1 centimeter above the suprasternal notch. Left lobe was 10 into 5 centimeter. A huge swelling was extending laterally up to the posterior border of the left sternocleidomastoid and superiorly up to 1 centimeter just below the angle of the mandible, and inferiorly 1 centimeter above suprasternal notch in the midline and up to medial 1/3 of the left clavicle laterally. And the swelling was not fixed to the skin and the underlying structure. The swelling is moving with deglutition, and the lower border of swelling is palpable. And trachea shifted somehow, slight shifted to right side. And one lymph node of size 2 into 1 centimeter is palpable in the left level 3. Two lymph nodes of size 1 into 1 centimeter palpable in left level 4 and level 5. And lymph nodes are mobile from deeper structure, smooth in surface, regular margin, and hard to form in consistency. Carotid pulse. The left carotid appears slight weak and displaced laterally. The right carotid appears normal in position and volume. Examination of the cervical spine was within normal limit, and oral cavity, no abnormality detected. On percussion, there was a resonant tone over the manubrium sterni, and no bruit was heard. On systemic examination, no abnormality detected. So my provisional diagnosis.
No, summary. Give a summary. Summarize the case. Give a short summary about the presentation and your finding.
The 46-year-old female presented with swelling in the front and left side of her neck for past 12 years, and which increased suddenly in last 6 months with the lymph nodes on the left side of her neck, and there is also respiratory distress while lying down, but no breathing difficulty or no breathing difficulty at sitting posture or during walking, no difficulty in swallowing, and no hoarseness of voice, no voice change, and no symptoms or signs suggestive of hypo or hyperthyroidism. And on general survey, the patient was normal. On local examination, the thyroid was enlarged, usually enlarged, and mostly on the left side. And the swelling was not fixed to the skin or the underlying structure, and the swelling was moving with the deglutition. Lower border of the swelling is visible and palpable also. Pemberton sign was negative, and systemic examination was within normal limit.
Lymph node examination, you said?
Yes, I said on lymph node examination, sir, I found lymph nodes in level 3, 4, and 5, and the level 3 lymph nodes was a bit larger than the others.
So again, the examination is fairly comprehensive. Maybe I have just one comment to make. If you are clearly saying both on inspection and on palpation that the lower border of the thyroid is visible, then maybe Pemberton sign is not of much importance. Pemberton sign is to make a slightly retrosternal goiter prominent and to check whether there is significant prolongation into the PA. If it is clearly palpable, the lower limit is clearly palpable on inspection and palpation, there is no question of Pemberton sign being positive. But anyway, maybe there is no harm in mentioning it that you have mentioned Pemberton sign. Swelling moves up with deglutition. What are the other swellings that move up with deglutition in the neck?
Sir, thyroglossal cyst, any lymphadenopathy attached with the larynx or trachea, laryngocele, or the subhyoid bursitis.
Okay, fair enough. So this is so. What's your provisional diagnosis? This is your. This is more like. Okay, fine. You said probably malignant in nature. So malignant thyroid swelling presenting as a multinodular gout, right? With cervical, ipsilateral cervical lymph node.
Yes.
Sir, would you like to add anything else, or can we go ahead with the management now? I think she has made a fairly comprehensive.
Actually, you have said you could palpate level 3, level 4 nodes. You see, the way you describe the thyroid swelling, I cannot see the picture, but if there is a large thyroid lobe there, sometimes it is difficult to specifically say lymph nodes underneath, because it described a very large swelling on the left side of the neck. And this thyroid swelling may overlap this area where you're talking of level 3 and level 4 nodes. Okay. So that you have to be very careful. You must feel a separate swelling, which should be mobile, and you can make out the margins also. Otherwise, it can be just a thyroid lobe which is irregular, because it is difficult to palpate level 3, 4 nodes when they have a large thyroid swelling. That you have to keep in mind.
So that swelling, that lymph node in the level 3 was so very fairly palpable, sir, and it's mobile and globular.
Right. So you have a diagnosis of carcinoma thyroid, lymph node metastasis, and patient is in new thyroid status.
Yes.
Okay, fine.
So what next?
Sir, I will do quadruple testing. The first thing I've done, the history and examination. So then I will move with the radiological examination. I will do the USG of the neck.
Ultrasonography of the neck. Okay.
Yes.
So what are the information that you are looking for in an ultrasound? What do you want to know?
So I have palpated multiple nodules, so I will confirm with the USG whether it is single, multiple, whether there is cystic swelling or solid or complex, the echogenicity of the swelling, whether any echogenic foci are there or not, the margins, the calcific, if there any presence of any calcification, or is that the capsule is intact or not, or invasion. Invasion, not in the USG.
Invasion not in USG. Invasion not in USG.
CT.
Why not in USG?
CT is better. Invasion.
Yeah, CT is better, but we are not asking you whether it is better or worse. Can you talk about invasion on ultrasound or not?
Yes, sir.
Yes, definitely. If it is closely infiltrating into the overlying muscle, if it is encasing the vessels, a good sonologist will definitely tell you that on ultrasound. Extrathyroid extent with even to the trachea with a high resolution ultrasound, they can tell that. Why not? Maybe CT is better. That's a different issue. So since we are on the topic of radiology and ultrasound, can you tell me what is thyroid score for thyroid?
So in this case,
not in this case. Not in this case. What is thyroid score? What is the full form? What are the things seen? Any idea?
Sir, in the thyroids, we see the shape, the echogenicity, the echogenic foci, the margins, the calcification.
No. Calcification is part of echogenic foci. You have already mentioned that. Calcification is not a separate point. The echogenic foci that you are talking about are nothing but calcification. What
the
else?
composition?
Why that tolerance is important?
Shape. She has mentioned shapes.
Shape. The shape, composition, the margin.
Right. So 5 things. I think you have mentioned all of them in a slightly haphazardly. So shape, composition, margin, echogenicity, and echogenic foci.
Echogenic foci. Yes.
So completely cystic swelling will be anechoic, whereas a partly solid cystic focus will have some echoes. So a thyroid malignancy, how is it compared to the rest of the thyroid parenchyma normally? Is it hypoechoic or is it hyperechoic? Commonly.
Sir, hypoechoic. carcinoma.
So hypoechoic is more worrying than hyperechoic,
yes,
if you are thinking about malignancy. Quite correct. And echogenic foci, what is the most significant kind of echogenic foci?
So most significantly, the higher number we give to the punctate kind of foci.
Correct. Very good. Fine. So you have a score, Thyroid score, on the basis of which you can categorize the risk of it being a malignant as low or intermediate or very high. Okay, highly suspicious. Fine. So that is about ultrasound. So suppose ultrasound gives you that it's heterogeneously, predominantly hypo. You have an ultrasound report for this, or should I make it up? Do you have the ultrasound report?
No, sir.
Okay, fine. Very good. So say ultrasound report comes as there is a swelling which is mainly involving the left lobe and the isthmus of the thyroid gland with multiple nodules, and the nodules are heterogeneously hypoechoic, predominantly hypoechoic, and there is minimal extrathyroid extension. There is capsular breach seen posteriorly, and there is minimal extrathyroid extension. Along with it, there are multiple nodes, both on the left side as well as on the right side. The left side node, the largest is this. This is how the report generally comes. The vessels are okay. Now what? So they have given it as a thyroid 5.
Thyroid 5. So
Thyroid
that means
5 is what?
it's highly suspicious. So highly suspicious.
Yes. Because you have clinical feature also for suspicion of malignancy. Then what next?
Sir, I will do FNAC. So USG guided FNAC.
Yes.
Okay.
This must be USG guided because you have multinodular goiter.
So from the suspicious node to the more suspicious nodule.
Okay, so they have done an ultrasound guided FNAC from the suspicious node. Do you have the FNAC report, or should I make that up also?
No, sir.
You do not have. Very good, fantastic. So say FNAC comes. I am at a liberty to tell you anything. FNAC comes as Bethesda 4. Do you know about the Bethesda classification of?
Yes, the FNAC scoring.
Yes. So what is it?
It's also a suspicious of follicular, but suspicious of follicular neoplasm.
Follicular neoplasm. What is Bethesda 3?
Sir, it's undetermined.
What is
that? Atypia.
Atypia.
ATP or undetermined significance, or follicular lesion of undetermined, FLUS or AUS. So follicular lesion, that is also a follicular lesion. So they can see thyroid follicles, but they are not certain whether the nuclear features are suspicious enough to call it a cancer or even a tumor. But they can see follicles. So even in an adenomatous goiter, there will be some amount of follicle. So this is a Bethesda 4. Now what? Patient is not very keen on some sort of surgery. Patient is asking you, do I need to undergo surgery? See, the patient has it for several years. You said no. She has it for 9 years or something.
You started with quadruple assessment. Now a new addition is there with thyroid assessment. In this group, you call as a bodily indeterminate group. Bases are 3 and 4. So is there anything else you can add to this? Is now being done in SSChem. This test is now being done in SSChem.
Quite a few years now. I think 3-4 years they're doing it in SSChem.
Yeah, they're doing it. And it helps also. I've seen number of patients, and they could categorically say that there is no mutation and lobe to be revealed.
So sir has already given you a hint.
No,
any role of molecular profiling?
Yeah.
From FNAC sample to determine whether this Bethesda 3 or 4 you can observe, or you have to suggest operation strongly.
Yeah. So Uma, you have to now go beyond quadruple assessment. If you have a clear evidence of malignancy, there is no question of doing profiling at the pre-op stage. But this group of patients, Bethesda 3 and 4, you should consider doing some molecular testing. What are the important molecular testing you consider for thyroid malignancy? There are some defined, there are a lot more, but there are some defined genes for thyroid malignancy. What are those?
So one, so red proton genes.
One is red proton gene. What else? Have you heard of BRAF?
Yes, sir.
Have you heard of RAS?
Yes.
Heard of PI13K?
These are-
So these are the
No, sir.
few genetic markers which are now being available. You have one test known as multi-gene thyroid sequence. Okay, so you can ask for these tests are available in the commercial setup also. So why do you need to do this test? Why this molecular testing is required? Will it help?
Like in a red proton gene, sir. The
if
inheritance.
You find some mutation is positive, what does it suggest? You see, if you take Bethesda 4, particularly 4C, the risk of malignancy is more than 80%. You can safely go ahead with your conventional surgery. But if you have a added evidence in your hand that this is showing some mutation on BRAF or RAS or red proton gene, what your suspicion goes?
Mutation. So inheritance.
That is again a separate entity.
So basically, it strengthens your decision to go ahead with a radical surgery or surgery for a malignancy. So you might be a little more radical in your surgery. You would not think of, there are conservative surgeries also for malignancy. But if you get these mutations, then you are fairly certain that this is a malignancy, and you go ahead and counsel the patient accordingly. In Bethesda 3 possibly, it is even more helpful, because in Bethesda 3, you can consider observing the patient. If the patient is not having much, this is a florid case. It's a very large swelling. There are cosmetic issues. There are symptoms due to pressure. There are lymph nodes. But sometimes you may have a 21-year-old girl with just a 2 centimeter nodule in one lobe, which is just visible. When you extend the neck and ask the patient to swallow, you can make out there. The patient is not really very worried about it. Patient is not interested in surgery. So, and the FNAC is Bethesda 3. So it is fairly inconclusive. It could be benign also. The thyroid score may also be low. In such cases, if you have this mutation, that you have this BRAF V600E mutation, then you can say that no, although the FNAC is inconclusive, the molecular studies suggest that there is a high chance this can be a cancer. And so we strongly recommend that you undergo some sort of definitive surgery for this. That is how it helps you to consider. And the thing that you were talking about is also right. If the red mutation is there, specific, that might suggest that this is an index case of a medullary thyroid carcinoma. So that is important for medullary thyroid carcinoma. Although red is also seen in papillary, but that's a different mutation. But in papillary CA, it's more important to have a BRAF mutation. In case of follicular CA, it is the RAS mutation which is more prominent. So again, to distinguish between follicular adenoma and follicular carcinoma, on FNAC it is not possible. But if you add the molecular profile, then you can differentiate. You can not firmly, but there is definitely a added evidence that this could be carcinoma rather than follicular adenoma, and you can counsel the patient accordingly. Okay.
Yes.
So you've got
and
an
if you have
ultrasound.
lymph node enlargement, you do ultrasound guided FNA from lymph node, and you find there are some follicular cells in the lymph node also. So what does
then
it
that
suggest?
is the conclusion.
The metastasis.
Yes. So if you have metastatic node, then you are certain that it's a case of malignancy. Then what should be your plan? Would you like to do further staging investigations? Any staging investigation need at this stage?
Yes, sir. If lymph node is metastatic, so I will do CT thorax and CT abdomen.
Is it a standard recommendation?
CT abdomen also. No? I
Is
think
it a standard recommendation? You see, thyroid malignancy metastatic can be picked up in the post-op period. At pre-op stage, most of the DTC are what? They are hormone responsive or not? They do uptake radioiodine or not?
No, sir.
They don't take up radioiodine.
DTC.
Why wouldn't they take?
The different thyroid cancer are avid for iodine. Okay, but would you like to consider doing a whole body scanning in the pre-op stage?
No, sir.
Because
In the pre-op stage, we do
better than
not.
CT thorax, better than CT abdomen is whole body scanning to detect distant metastasis. Will you do it in the pre-op stage?
No, sir. We will do in the post-op stage.
Yeah.
So that is important. So in the background of suspicion of malignant thyroid nodule, especially if there is no hypofunction or hyperfunction, which you have mentioned, then there is no role of doing pre-op radioactive iodine scanning or pre-op thyroglobulin also. These two tests are not to be done in the pre-op period. Can you do some other test in the pre-op period, which has a kind of a plus minus recommendation? You may or may not do, depending on your claim. In this case, I would think of it.
Patient has some breathing difficulty.
The next CT for
I'm talking about a blood
invasion.
test. Let me give you a hint. I'm talking about a blood test.
So apart from the routine investigation,
apart from routine investigation, TSH you should have done. If it was a solitary nodule, you should have done TSH in the very first day. It is normal. TSH is normal. Anything
serum calcitonin.
Yes. This is a slightly elderly lady. She has got prominent nodes. So this seems to be a little aggressive tumor. You are saying that there is a recent increase in size. So although medullary carcinoma is very rare, can you tell me the incidence of medullary carcinoma overall in thyroid cancer? What percentage of thyroid cancers are medullary thyroid cancers?
So medullary less than 10%.
No, much less than 10%, around 5%. Okay.
5%.
10% is follicular. So obviously medullary is rare. You will not always get medullary, but you should keep your mind open to the possibility. So anything slightly different from the variation. So this is a slightly elderly lady, 46, not 20, not 25, not 18. She's got a large swelling. She's got a recent history of increase in size. She's got multiple lymph nodes. There is no harm in sending a blood test. It is not very expensive. It is not very invasive. You are sending blood anyway. So in this case, maybe you can do a serum calcitonin also. Okay.
And if another thing, you said CT scan. There are some conflict regarding recommended CT scan in the pre-op stage. Why CCT is not advisable in a patient who has got carcinoma thyroid? Some people have the reservation that use the contrast. How it affects post-op?
So it affects with the iodine uptake, sir, post-operatively.
Yeah. Right.
If we planning to iodine scan.
So we are planning, we will obviously do a radioiodine scan in this patient if it is malignant. So we are assuming that it has come out to be malignant and we are going ahead with surgery. So definitely we will do a iodine scan. So in this case, you have said on clinical examination, it is freely mobile. It is not fixed to the skin. On the ultrasound also, they have said there is just minimal extrathyroid extent. There is no significant invasion of surrounding structure. So a CT is not a must. If you are happy, you can consider not doing a CT. But many other people say that by the time we take up the patient for radioiodine, any iodine contrast that is given in the CT is washed out of the body. There have been studies on that also. So even if you do it, it's not wrong. But if your examiner, like sir asked, if the examiner has said, will you consider CT? Is there a problem with CT? You should know that iodinated contrast can maybe decrease the avidity, yes, with the post-op radioiodine evaluation. Right.
Fixed thyroid, retrosternal prolongation. You have to do some imaging.
Then you have to do axial imaging like CT, even if it interferes. But in this case, if clinically it is freely mobile, you are saying the lower border is palpable, it is moving up with deglutition, maybe you cannot consider. Okay, but you would do a chest X-ray. So when sir asks, what about staging? Chest X-ray is definitely recommended in the pre-op.
One thing I like to mention, sir. So in this case, I got left carotid slightly displaced, sir.
So if you have any suspicion,
displacement is not very important.
That is what do you call that? You did not mention that specifically by name. What is that known as?
So Berry sign.
Berry sign, yes, Berry sign. So a benign, the concept was that a benign swelling, however large, will push it away. It will not engulf it. And so you will still get the carotid pulsation, but it may be pushed away. Whereas in case of a malignant swelling, you may not get the carotid pulsation at all. So here you have said it is a little weak. So you have left it a little equivocal. So it could be this or that. Fine. So if you have a suspicion, you will definitely go. So you say that in this case, I am not very happy with the carotid pulsation. I think there may be some amount of invasion. And as you rightly pointed out, CT scan is better for delineating the invasion, the level, the extent than ultrasound. I would like to go for a CT scan because I don't want any surprises during the surgery.
Okay, regarding TNM, if you have carotid sheath being engulfed where does it place as far as T is concerned in the thyroid? If carotid sheath is engulfed, where do you place this tumor as? T1, T2, T3, T4, T4A, T4B? This is what? You have a positive.
This is a simple question. T1 is less than 2 centimeters within the thyroid. T2 is more than 2 centimeters within the thyroid.
Less than 4 centimeters.
Less than 2 to 4. 2 to you have to specifically mention. T3 is more than 4 centimeters or gross extrathyroid extension. And involvement of surrounding organ like carotid and all obviously will make it T4.
Yeah.
There
This is T4B. T4B is when you have prevertebral muscle, subapical vertebral body, and carotid sheath is engulfed. That is T4B. That you have to keep in mind because you need to stage the disease also. Okay, we assume this is the operable situation, and you have a situation of maybe they could say in FNA that it is a malignant lesion because of node also.
That is the 4
What
and
should
that is
your
the
plan?
5. And FNAC from node is also positive. What now? And
what is your plan?
Nodes on the left side, there are few nodes on the right side also, although they are smaller in size. Is the lymph node enlargement the only criteria? This is also a question which we have repeatedly asked, but still we'll ask you.
Okay. If the lymph nodes are enlarged, what you need to ascertain? Is it metastatic or is hyperplastic? How do you do that?
So any enlargement is
so by imaging by USG of the lymph node.
On ultrasound only. On ultrasound we are talking about. They have said that the size is increased. Is size the only criteria, or do you look for any other information?
No, sir. Shape of the lymph node.
What shape is significant?
Sir, loss of the bean shape.
So it has become rounded.
Taller than the wider, rounded.
It becomes rounded. Okay. Then what else?
So the loss of fatty hilum.
Correct. Loss of fatty hilum. Then what else?
It's an irregular surface.
Okay. Irregularity of the margin.
Irregular margin.
Okay. What else?
The vascularity.
Yes. So all these things together will make you think. So on the opposite side, the node may not be enlarged much, but if they still say that there is loss of fatty hilum or there is the shape is round shape, slightly heterogeneous ecotexture, then you have to think that the opposite side nodes may also be significant. Okay. But if it is just an enlarged size, but say it is enlarged inside 1 point, if it is more than 1 centimeter, it is enlarged, it is significant. But if they say the fatty hilum is preserved and it is oval in shape, then you don't attach much significance to it. Frequently, you will get cervical ultrasound saying that opposite lymph nodes are also enlarged. But size is not the only criteria. That is what we are trying to tell you. You have to look at these other features. Okay, so what is your plan? In this case?
So I will plan the patient for surgery, total thyroidectomy with the radical neck dissection.
The ultrasound said that the right lobe is normal. The involvement is of the left lobe and isthmus. Why do you want to do a total thyroidectomy? I'm not saying you're wrong, just justify.
What is the advantage of doing total thyroidectomy in the background of a clear diagnosis of malignancy in the thyroid? Think of the patient age. Think of patient age. Think of the nodule size. Okay, think of the surgery and the post-op period. So answer on these lines.
Because so it is a malignant. So
you mean to say all malignancies require a total thyroidectomy? All malignancies of thyroid, differentiated thyroid?
No, so the isthmus is enlarged and the swelling is also very huge. So
what is huge? What do you mean?
What is the criteria of size?
2 centimeters is also big. 2 centimeters.
What is the criteria for size in papillary and follicular, where you take the patient to higher risk group?
Are you aware of the risk stratifications for thyroid, differentiated thyroid cancer? Risk stratification for planning treatment?
So that ages.
Yes. What does age stands for? Age stands for what? Ages?
The age of the patient. In case of female, 40, less than 40, or in case of male, less than 50. Less.
No, it's absolutely the other way around. 55 and 45. Female 55. Females have a better risk. So you tolerate a higher age group. A female of 50 is also low risk, but a male of 50 is high risk. Higher age for female, lower age for male. Carry on. That is A. What is G?
G is what?
Then G for the grading of the tumor, whether it is undifferentiated or well differentiated.
Are you aware of the grade? Are you aware of the grade now?
Yes, sir. She is more than 40.
No, grade. This is the patient. Are you aware of the grade?
Oh, no, sir.
So this is not a pre-op factor. You cannot use grade in the pre-op decision making, but you have the decision has to be made pre-op, whether you're going to do a total or you're going to do a hemi. So that is one drawback of ages. Okay. So can you tell me another scoring system where the grade is not there? Another risk stratification system?
What is EMIS?
AIMS or EMIS, whatever you call it. You must know a few of them: ages, MS, masses.
Age,
these three you should
metastasis.
know.
Metastasis mean clinical evidence of metastasis or imaging metastasis.
Distance, yeah, any of them. E is extrathyroid extent and S is size. So this is all these features you can get.
Yeah. Size 1 centimeter for papillary and 4 centimeter for follicular lesion.
4 centimeter for follicular.
High risk.
So in my opinion, AMS is a better option for doing a risk stratification than ages. Because ages grade you do not get in the pre-op period. You can only get it after the operation is done and you get the histopath report. By that time, then you can tell the patient, okay, now you are in high risk, you need another surgery. If you have done a hemithyroidectomy in the first. So using AMS, so what now that we don't know whether it is papillary or follicular, you said this is a huge size. What is huge size? So anything more than 4 centimeter would definitely, the recommendation would be a total thyroidectomy. Less than 1.5 or less than 1 centimeter, most experts would go for a lobectomy or a hemithyroidectomy, whatever you want to call it. Americans say lobectomy. So in between, there are other things that you have to see. Anything between 1.5 to 4, you have to decide on a case per case basis. You have to see the patient's desire, you have to see the patient's age, you have to see extrathyroid extent and all these things. So even a 1.5 centimeter, which is absolutely posteriorly placed with extrathyroid extent, you should recommend a total thyroidectomy. Okay. Whereas a 2 centimeter, which is well confined into the lobe, no extrathyroid extent, she's a young patient, she is committed for follow-up, you can consider a hemithyroidectomy.
Lobectomy.
Okay, lobectomy. Okay. So individualization based on risk stratification. So this patient, you said by your description, it is definitely more than 4 centimeters. So your decision of a total thyroidectomy is justified. Anything else that you would like to do? Sir was also asking, how does it help in the post-op period? You know, sir gave you guidelines. You answered around this to justify total thyroidectomy. What about the post-op period? This is the size criteria. What else?
If you've done a total thyroidectomy, it is easier to follow up these patients to detect disease in the neck or metastatic.
During the radioiodine scan, if there is no normal tissue, so if there is any metastatic tissue present anywhere in the body, it will uptake better.
So you answer like this. So total thyroidectomy helps in detection of detection of distant metastasis. It helps in post-op treatment using radioiodine, and it also helps in follow-up of the patient.
And thyroglobulin.
With thyroglobulin and
thyroglobulin.
So all these things are better done with total thyroidectomy. So that is a logic for doing total thyroidectomy in all cases. When we were under postgraduate students studying under sir, there used to be this debate whether hemi or total. Nowadays there are more refinements. The molecular markers are there, more studies are there. But in those days, these were the decision making. These were the reasons for doing total thyroidectomy in all cases. So what is the reason against doing total thyroidectomy?
Against
total thyroidectomy in all cases. These are good advantages. No, you can detect metastasis. You can follow up using thyroglobulin. You cannot do all of these if you do a hemithyroidectomy. So then why not do it in all cases?
Actually, one point was multifocality of the tumor, but all tumors are not multifocal. 1 point for total thyroidectomy was multifocality.
Absolutely.
So all tumors are not multifocal.
PAPCA, thyroid. Do you have
So
any
there will
idea
be
how frequently papillary thyroid cancer is multifocal?
no.
It is very common. You know, autopsy series of deaths due to other reasons. Patients who have died of road traffic accident, patients who have died of renal failure, patients who have died of heart attack. They did a study. They removed the thyroid gland and sectioned it, and they found focals of papillary thyroid cancer in more than 20% of cases. So many of us who are there in this seminar right now may be harboring a occult focus of papillary thyroid cancer. In all probability, we will spend our life without knowing about it. So the significance of these occult multifocal lesions are not known. So that is why we don't base our decision making on the possibility of multifocal. So multifocality may be there, but it probably doesn't influence if it is clinically occurred.
And if you have other risk factors on the less risk side, you can take a chance for not doing a radical surgery. Because what is the problem with radical surgery?
Yes, that you have to say. What is the point against total thyroidectomy?
So there will be no normal thyroid tissue left behind.
Before
So
that,
how does that
technically, that is one reason for avoiding total thyroidectomy.
The patient becomes hypothyroid.
Patient may become hypothyroid even after hemithyroidectomy, you know. There is no guarantee that the patient will not become hypothyroid after him. Although the risk is obviously much less, but the patient may become. And anyway, post-op after hemithyroidectomy,
you have to give thyroxine.
You have to give thyroxine for suppression. So you are not saving the patient from thyroxine. What are the other problems?
More important is technical part. If you are doing thyroidectomy and the surgeon is not experienced, you can land up with some problems. Two important common problems.
Recurrent laryngeal nerve injury.
Nerve injury. Don't say recurrent laryngeal nerve. Say nerve injury. There are other nerve injury.
And nerve injury and hypoparathyroidism. These are the two important technical aspects of the operation, which you can avoid if you are not doing a total thyroidectomy. But with experience, people are saying that this is not a hindrance for doing a radical surgery.
So in your case, the plan is doing a total thyroidectomy. What about the neck? What about the neck nodes?
With the radical lymph node dissection of the left side.
Dissection. What is radical lymph node dissection?
You do radical or something different?
What will you call it?
The modified radical lymph node dissection.
Yes.
Neck dissection. We don't call it
neck dissection.
Modified radical neck dissection. What are the structures you remove in radical neck dissection? Now that you have mentioned it, we will ask you that you don't remove in modified radical neck. What are the structures that you remove in radical neck dissection?
Name 3 structures which are removed, and then based on this, you would classify into type 1, type 2, type 3 R&D.
So in radical, we remove sternocleidomastoid of that side, IJV, and spinal accessory nerve.
Good.
So okay.
So what is
type 1? In the modified, we can spare these.
One or more of these in different combinations. So in type 1, you spare the spinal accessory. In type 2, you spare the spinal accessory and the IJV. In type 3, you spare all 3 structures. Okay. So here you have decided that you will do a modified radical, right? What are the lymph node levels you will remove? On which side you will do it? On the left side. What about the right side? Right side?
The right side, there is no lymph node palpable, so I can.
And nothing on the ultrasound also. So you will not do. Okay, fine. Anything else? Anything else?
You remove from 1 to 6, or you can spare some level.
So level 1A, 1B, so they do not drain. So level 2, 3, 4, 5, and that pretracheal, that level 6.
What is that
level
called?
6? So
the common,
central neck node.
Central neck node. So you have to say central neck node first. That is the first echelon draining node. So if the lateral node is positive, you have to consider that the central nodes may be positive. You may palpate it, you may detect it on ultrasound, you may not. But there is a high chance that central lymph nodes will also be positive. So you have to do a central compartment dissection.
Uma, what is the demarcation for central node? Yes. What is the demarcation for central node dissection? Demarcation?
You are operating. Central, sir, up superiorly, hyoid bone. And inferiorly, suprasternal notch, or that innominate vein.
Left
on either side, right? Then, on either side,
sir, on either side, medial border of carotid sheath.
Okay, fine.
Yes.
So that
Fine.
is central compartment.
Yeah.
So you said there's a problem with nerve injury during surgery. So what are the nerves that are at risk? Quickly, we are running out of time.
So recurrent laryngeal nerve.
Branch of recurrent laryngeal is a branch of.
Come on. Large nerve trunk, which is the carotid sheath going down. What is that nerve? Which nerve runs in the
Sir is giving
carotid
a lot
sheath?
of hints today, I must say.
The branch of
Vegas,
Vegas.
Baba, Vegas. So
Vegas.
which recurrent laryngeal nerve is more at risk?
Sir, left side.
In what way? In what way is the left side more at risk?
It's longer in course.
So that is for pathologies of the thorax. I am talking about surgery. During a thyroid surgery, which one is at risk? You are just addressing the neck. The right side has a more inconstant course.
So closer,
it's got a more
closer,
oblique course, more oblique course, but rather more
closer.
transverse course. What is the non-recurrent recurrent laryngeal nerve?
Non-recurrent. That means the nerve is going straight from Vegas to the thyroid membrane.
So that is more common on the right side, almost exclusively seen on the right side. So that is a very dangerous condition. You will keep searching in the normal place, you will not find it, and then when you are taking the vessels, you will injure the nerve. So the right side is more at risk actually. For general pathologies, you are absolutely right. Left recurrent laryngeal, because it is a longer course, thoracic pathologies will involve it, whereas it will not involve the right side. But during a thyroid surgery, for a beginner, it is the right nerve is more at risk as compared to the left nerve. Left nerve is oblique right from the start. So if you just stay parallel to the thyroid lateral border, you have less chance of risk injuring the left-sided nerve. Okay. Do you know some of the triangles in relationship to the nerves that help you identify? Actually, what is the other nerve? Forget this recurrent laryngeal nerve. What are the other nerves that are at risk? Or is this the only nerve that you have to worry about?
Any nerve in the upper pole which may get injured?
Upper. The superior laryngeal.
External branch of superior laryngeal nerve. EBSLN. Do you know of Cernia's classification? Is the superior external branch of superior laryngeal nerve always having the same anatomy? Does it cross above the superior pole or below the superior pole once it enters the cricothyroid membrane?
No.
So there is a Cernia's classification. Most commonly, it crosses the thyroid above the upper limit of the pole. It crosses the vessel. So if you stay close to the upper pole, when you are ligating the superior thyroid vessel, you will not injure it. 60% of time it is type 1. But 20% of time it is type 2A and 20% of time it is type 2B. Type 2B is when it is actually crossing the thyroid below the upper limit of the upper pole. So both 2A and 2B are at risk when you are ligating the upper polar vessels. What are the blood vessels that you have to take while doing a thyroidectomy, whether hemi or thyroid? On one side, what are the vessels that you have to take?
First vessel to tackle.
Classical teaching, we were always taught like that. First, you have to identify the
inferior thyroid artery.
No. Much before
middle thyroid vein.
Middle thyroid vein.
Vein.
It is supposed to be so short, fragile, very thin walled, short and slightly dilated. So while you are mobilizing the thyroid lobe, we tend to pull the thyroid lobe out medially from underneath the sternomastoid. If you put too much of traction, you may actually tear the vein and there may be bleeding immediately and it will spoil your field and it is problematic. So before you have done too much of mobilization, check the lateral border, check the middle thyroid vein and ligate it off, and because it is thin and fragile. I mean, short, not thin, short, and obviously it is thin walled and fragile. Okay, middle thyroid vein, that was first. Then you go to superior pole. Then you come to inferior pole. That was a classical teaching. But during operation, you can do it any way you like, whichever is convenient for you, case wise.
Where is the inferior thyroid vein, Uma? Where is the inferior thyroid vein you ligate? Does it follow the artery or is it in different place?
So inferior.
Here you need to do a lot of thyroid surgery. You must observe.
And you have to do a little bit of study of anatomy and surgery part. The other thing was good. I don't like going too much into the
inferior artery and vein are not lying close by.
They are not adjacent. They don't follow the course. The vein doesn't follow the course of the artery. Normally, the veins follow the course of that. Left gastric vein is along left gastric artery. Right gastroepiploic veins are along gastroepiploic artery. Colic, middle colic artery veins are all parallel. But the superior thyroid artery, superior thyroid veins are just next to each other. But inferior thyroid veins, they are totally different. The inferior thyroid artery is a branch of coming from subclavian, the thyrocervical trunk. So that enters the lateral border. But the inferior thyroid veins go from the lower pole. They don't exit from the lateral border. There are generally more than one, and they drain from the lower pole directly into the innominate vein. Okay.
Yes.
Okay.
So what will you do? You have assume that you have done a total thyroidectomy, and the histopath comes as PAP-C8. The tumor size is 4.5 centimeter. There is a minimal extrathyroid extent, like there was served, and 3 out of the 23 left-sided nodes are positive. What next?
Discharge advice. Patient is going home. You have done a good surgery. What is the discharge advice?
So I will
one question about the surgery. Post-op, we talked about the nerves, which we will generally realize in the immediate post-op period. What are the other things that you have to watch for, specific for thyroid? Don't say hemorrhage and all those things. Post-op period, what complication do you have to look for? Total thyroidectomy done.
Total thyroid. Sir, hypocalcemia.
So how will you detect it? How will you detect it? When will you detect it? First post-op day? Or immediately post-op?
3 to 4th day.
Okay, so 4th post-op day is the commonest presentation of hypocalcemia. How will the patient present? What will the patient say? What are you going to look for in the ward?
Sir, tingling of hands, feet.
Okay, fingers and toes and around the perioral region. Perioral region. Suppose the patient, sometimes patients are not very intelligent. They don't understand your language well. So they are not answering. Any test that you can do? Third post-op day, there is no symptom as yet, but you are very concerned. During the operation, you could not really identify and preserve the parathyroids.
Simple test, simple bedside test. I used to demonstrate this in the ward. If you tap in front of tragus, what can happen?
Sir.
If you tap in the forehead, what can happen?
Spasm.
Yes, twitching of the facial muscles. That is known as Chvostek's sign. Chvostek's sign you have to mention. CHVOSTEK. Chvostek's sign. Okay. Tapping in front of the tragus over the trunk of where the trunk of the facial nerve exists will cause twitching of the facial muscles around the lips and the eyes. And that can be done even before the patient has clinical symptoms or signs.
Yeah.
So, and then you can be cautious that, okay, so immediately you send the blood to document and you start the patient on what do you start the patient on? Suppose the patient goes into spasm. How will you give the calcium? What calcium will you give? Patient, suddenly you get a call from the ward, the patient is having a spasm, and you go and see it, the patient has got a typical position. What is that called? Carpopedal spasm, right? Carpopedal spasm. You see the hands are extended and the thumb is adducted and the feet are also hyperextended.
Another Trusu sign. This is another Trusu sign. Trusu sign has other situation also, but this is one of the Trusu sign.
Yes, that can also be done by
I will.
What do you give in the ward?
How will you manage?
Sir, IV calcium gluconate.
How much? How much? How much IV calcium gluconate? Bolus. You immediately draw a bolus. No, you don't give bolus. You never give bolus. Be very careful. You cause cardiac arrest. Never give bolus. So you give as a slow infusion. It may look like an emergency, but it is no emergency. Okay, the moment you start giving calcium slowly, in 10 minutes, patient will sit up and smile and say, "Doctor, you are gone. I'm totally fine now." Don't be in a hurry. I mean, don't waste time, but don't be in a hurry and never give bolus. Okay. So the classical teaching for us was 10 milliliters of 10% calcium gluconate over 10 minutes IV. Over 10 minutes, mind you. No bolus. But that is too troublesome. Who is going to stand there and give 10 milliliters over 10 minutes? So easier is to charge, say, 2 ampoules in 100 ml NS and give it over 30 minutes. 100 ml NS, you can give as an infusion over 30 minutes. And you don't have to stand there and push slowly and wonder whether you're pushing too fast or too slow. So do that. Don't get scared. In 10 minutes time, patient will sit up and smile. Okay. Okay, fine. So that is post-op. Hypocalcemia to be taken care of. Now, what is the discharge advice? Like I said.
Sir, if the lymph nodes are positive, then we can
suppose lymph nodes are negative. Second case, lymph node is negative,
Negative.
but everything
So-
else is
so
same,
we can-
4.5 centimeter.
So patient can be discharged with routine painkillers and
No, we are not asking that. What further treatment?
Oh.
Quickly.
so
Will
just
you write
follow up,
L-thyroxine
follow-up
and the
patient.
discharge slip? Will you write L-thyroxine in
So
the discharge slip?
initially, no. So in the discharge, we do not give the
Why not?
L-thyroxine.
Why not? You have done total thyroidectomy. Can the patient live without thyroid? Why will you not give?
So, we have to do iodine scan
So say that.
Best
You have to
line.
6 weeks,
advise.
4 to
You
6
have to
to
weeks.
advise
do
for
a
radio iodine.
baseline whole body scanning. This is
Hmm.
baseline whole body scanning.
Hmm.
For that, you need to have high TSH.
Ha-
So don't
high
write
TSH.
L-thyroxine in the discharge certificate.
So we will make the
Ask
patient
the patient to come for
hypothyroid.
follow-up. At what
Hmm.
interval she'll come? After what date she'll come for follow-up or assessment? Yes, TSH is going up or not? How long usually it takes? What is the half-life of circulating thyroid hormones?
So for T3, it's 7 days.
And
It's
what's the T4?
T3 shorter, no?
T3 shorter,
2 to 3
shorter
days.
half-life.
T4 is around 7 to 14 days.
Yeah. So it takes at least 2 weeks time for the circulating hormone to come down and takes little more time for TSH to go up. So follow this patient up at the end of 2 weeks, 3 weeks,
2 weeks.
and then TSH study and go for whole body scanning.
Whole body.
Dr. Ghosh, we have gone
Run
beyond
out of time.
You must be
As
busy in
usual.
hospital.
As
Yeah,
usual.
yeah. Okay.
sir.
Thank you. Thank you very much. Thank you, Uma. You presented well.